Hey, and welcome back to the Overrun on YouTube. My name is Ed Bowder.
I'm Dan Truster.
And today we are joined by Salim Rezaie out of Texas, the creator, founder, and writer, editor, and Lord of all that he oversees at Rebel EM. uh, Salim, thank you for joining us today. I appreciate it.
I appreciate you guys having me. This is a good topic we're going to be talking about today.
I'm really excited for it. So in January, you put up a thing on Rebel, and this will be linked in the show notes, on the use of pre-hospital antibiotics and sepsis. This is a conversation that I feel like for EMS we've had for, it feels like decades, but
This has been
yeah.
hanging around for 10 years.
And the conversation was essentially, well, if we can get people who we think have sepsis antibiotics pre-hospitally, we can reduce their treatment, reduce their time in the hospital, and all this other stuff. But there's probably extra things that we should talk about it as well. So what I like about what you wrote in January was you reviewed this paper by Varney et al. That came out in 2022 that was a meta-analysis on sepsis. So talk to us a little bit about what you think as far as antibiotics pre-hospitally are concerned, and then talk to us a little bit about this paper, and then let's kind of get into the details of it.
Yeah, I mean, so the first thing is, everything that we do for patients, there's pros and there's cons. Nothing is absolutely perfect that we do. And so we have to weigh those two things. And what I find with this concept of pre-hospital antibiotics is it's one of those things that like makes us feel like we're doing something, but like, are we really actually doing something that's beneficial, or have we not considered the potential harms of what we're doing? The second part of that is that, time to antibiotics, which is, driven by the surviving sepsis guidelines and all the recommendations that they make, it's from a time of triage, not from the time of infection starting. And so it's just this like arbitrary time point that somebody calls and says like, I don't feel good. And then we check SIRS criteria and they meet 2 of the 4 SIRS criteria. And now we're on the clock to start getting them this antibiotic. And so I think it's important to ask is faster better? And is faster necessarily maybe causing harms? And so that's why I kind of reviewed that meta-analysis and why I kind of have some strong feelings. The third part of this is, I will be like full disclosure, the EMS agencies in my area are all giving antibiotics for patients that meet 2 out of 4 SIRS criteria. And to be clear, because I've had this come up on social media discussion, like if you have somebody who has like an open fracture and it's like dirty, you want to give antibiotics, give antibiotics. Like I'm not gonna argue with that.
Yeah.
But like,
Sure,
but
the
SIRS criteria,
stuff.
yeah, the obvious stuff. But like SIRS criteria is so non-specific. Like somebody having an asthma attack is going to have SIRS criteria, and
Sure.
we're just going to be throwing antibiotics at them like willy-nilly. It's not very specific, right? It's a sensitive kind of marker of badness, but not all things that check the boxes for SIRS or sepsis are actual infection. So that's kind of the point
Right.
of like why I talk about this.
And I worry in the field that we kind of quickly now, because sepsis and SIRS became very, very popular in the literature over the past 5 or 10 years. I worry that we kind of run towards sepsis, right? Any fever, any even altered mentation is, well, it's sepsis until it's proven otherwise. And Dan, I don't know if you've seen it more in the field, but it feels like when we get dispatched, like the example that we can give is, say like a nursing home, right? Or a SNF or extended care facility. You go in and the patient is 78 years old and you're like, oh, this is a UTI. Right. And I don't, Dan, I don't know if that's been your experience or if that's what you tend to think here, but it feels like, every third dispatch is like, this is either sepsis or it has the potential to be sepsis.
Yeah, I've seen this a little bit. I think there's been a creep, especially since sepsis became known and it became faddish. It became the new hot thing, and everybody was looking for it. And we led to a lot of these. I mean, I'm old enough to remember goal-directed therapy and all these little metrics that we had to hit, and it hasn't shown to be beneficial. I remember listening to the MCREP podcast with back in the day with Dr. Rivers and talking about his, the goal-directed therapy stuff and the central lines and the fluid boluses. And then everybody loved it and jumped on board with it and embraced it. And then it was wrong. I think we're doing that pre-hospital now. I think you're right. I think we're mission creeping because I don't think that we're proficient enough in determining what truly is sepsis. I don't think we don't, for the most part, have the tools to make those decisions. And I think we're guided in a lot of instances by these metrics that I don't know if they're there to mark that we're doing things to make us feel better, or like Dr. Rezaie said, are we making the patient better, or are we making us better? Are we making us feel better? And I don't know, but I definitely seen the creep in the field.
Salim, I want your thoughts on that because
I don't think it's that people pre-hospitally can't make clinical decisions. I think that's the wrong statement. I think it's a patient who's sick that's very information light. You just don't have all the specifics to make the decision. It's not that you can't make decisions clinically. It's just, you just don't have all the data points to say okay, this is definitely this is truly an infection. But like I said at the very beginning, if it's something that's completely obvious, well, I don't think anybody's going to argue, but that's the problem is that people present with vague complaints and we just assume sepsis, but we just don't have all the data points that we need pre-hospitally to definitively say that. And so then now, if that's the case, we're just willy-nilly just throwing antibiotics at everyone. I mean, we might as well just put it in the water, right? If it was a benign thing and it was helpful, we might as well just put it in the water, because that's essentially what you're doing.
Everybody gets it.
Everybody gets it. Everybody gets Rocephin.
You get ceftriaxone.
It's really a nuanced kind of decision. Somebody has an infection, that's one thing. Somebody who's septic, it's different. And you need a lot of different data points to make that determination in the field. And I don't know, like I said before, I was saying, maybe I kind of said it the wrong way, not having the tools you do, but you have to apply them, and you have to apply them consistently. And I don't know that every program nationwide or every pre-hospital program in the world is doing that. So I think we get stuck with SEERs because it's easy, and it's oh, they're tachypnic, they're tachycardic. It's sepsis. We had my place, we were using lactate meters for a while, which was interesting. But again, it was cool after everything else got done. Oh, and doc, by the way, the pre-hospital lactate's 3.6. It wasn't just that, but some people looked at it as, oh, the lactate's high, it's got to be sepsis, or they're tachypnic and tachycardic. It's more than that. It's a whole holistic approach, and I think we need to be more in tune with that.
Yeah, I think that's probably right. And what I think is, and one of the things I think we do in EMS a lot is when there's a new, cool thing that comes out, I think a lot of people tend to kind of jump on the bandwagon. And certainly there's examples, 5-10 years ago, we're oh, this is the new exciting thing. And then we find out, no, it's not. And, there's plenty of examples that we can talk about. But one of the things that I think is important in this analysis is there was a bunch of studies that came out of the Netherlands. They call it the fantasy trial. And it's fun because it's fantasy with a PH. So it's it's a fun little acronym that they got for it. But essentially what they were looking at was, are pre-hospital antibiotics effective? And I'm not convinced that that's the question anymore. I don't think that there's an argument that antibiotics do or don't work. I think the more interesting argument is, are we causing any benefit by giving all these antibiotics pre-hospitally? So this 2022 study kind of looked at that. And Salim, I'm interested in your opinions of what the data found versus how we can actually apply that in the field.
Yeah, so they ended up finding 4 studies that were eligible for their meta-analysis, and the fantasy trial was one of them, which, by the way, was the only randomized clinical trial that they included in this meta-analysis. And when they looked at pre-hospital antibiotics versus no pre-hospital antibiotics, What they found is pre-hospital antibiotics did reduce mortality 10.7% versus 16.7%. And that was a statistically significant finding. But there's always a devil in the details. And so if you just look at it broad strokes and you just read the abstract, you're like, see, I'm doing this good thing. And so I want to
You
talk
see,
about
it
that.
says.
It says though, it works. There was no decrease in length of ICU stay. There was no decrease in length of hospital stay. So, and I think mortality is a good patient-oriented outcome. And the reason why I say that the devil is in the details is you have to look at the individual studies of the meta-analysis. So if you put a bunch of crap into a meta-analysis, the result you're going to get is crap. And so, you know, you can't
Garbage
just
in,
take
garbage
it.
out is something we've
Garbage
heard a
in,
million
garbage out.
times now, right?
Okay.
Yep.
So 2 of the 4 studies that were included in this meta-analysis, when they did the quality assessment, were at high risk of bias. In other words, their methodology was flawed. And unfortunately, those 2 studies were over 70% of the weighting of this meta-analysis. So you put in 2 flawed studies that are 3/4 of the weight of this meta-analysis, then you're going to get a flawed result. So that's number one. The second thing is, although they looked at mortality as their primary outcome, the individual studies that were included did not have mortality as their primary outcome in all the studies. They were secondary outcomes. And that means that the individual studies were not powered to look for that outcome. So yet again, another methodological flaw. And then the final thing I'm going to tell you is that 3 of the 4 trials were observational, and there was only one randomized clinical trial, which is the fantasy trial, which we can talk about a little bit more. I don't think it was a great study either, but we can certainly talk about it. But it's really hard to draw definitive conclusions from observational studies. You can find association, but you can't find causation. And so that was the majority of these studies that were included. And so from a methodologic standpoint, huge issues. And although statistically significant, which is the headline, there are major problems with what was included. So I don't necessarily buy that the pre-hospital antibiotics are really making a difference in mortality. And then there's a flip side to that coin, which obviously we're going to talk about here in just a bit.
And, you know, of course, you know, we want to look at mortality and how it changes. Whenever I see a data set that says that mortality wasn't changed or, you know, hospital admissions weren't changed, at that point, I'm just kind of like, okay, then why did we do it? And I can appreciate the want, right? So we know that antibiotics work, so it would stand to reason that giving antibiotics would reduce, you know, these negative outcomes. But at the same note, when you're doing a study, if your only tool is a hammer, everything looks like a nail, right? So if you're deciding before you publish the study or even before you get into the study what you're going to find, then yeah, of course you're going to find it. And that's a flaw I think that you find in a lot of studies. And that doesn't even get into talking about just the generalized risk of just giving antibiotics, right? We already have entered into a realm in medicine where antibiotic resistance is at an all-time high. And this is something that I think we talk about, right? But I'm not convinced that we really have sort of internalized it, where if people are resistant to antibiotics, we don't have another option. Like that's kind of where it stops, right? And just giving a lot of antibiotics pre-hospitally on a large scale, I think just kind of, you know, exacerbates that problem.
Well, I'll tell you that the number of resistant bacteria is going up significantly faster than the number of antibiotics that are coming out. And so if we just keep using this stuff like it's in the drinking water, we will get to a point where we will not have options to treat people. And so although it's in the short term maybe beneficial, and I say maybe because I've yet to be convinced that it is, because I think the metric is flawed. But we're basically, it's like today's society, right? Like everybody wants that instant gratification. And that's what, to me, like pre-hospital antibiotics are. It's like instant gratification without thinking about the delayed consequences. And that's the part that I never hear anybody talking about, is the delayed stuff. And so we can talk about that a little bit more, but it's not benign to just give antibiotics faster to everybody who meets SIRS.
And in the field, we got to remember, like, if you're doing this pre-hospital, these are broad spectrum antibiotics. These are napalm. This is not something that's a targeted, for a specific type of bacteria or anything like that. This is literally like, hey, everything over there gets wiped and we just see how it works.
Right.
And you use that enough times, you're going to run out of things in your quiver. It's not a smart move.
Yeah, I call it
So let
gorillacillin. We're just giving them gorillacillin.
Ooh.
That's what we're giving
Oh, I
them.
like that. That's good. I like that a lot. So let's talk about some of the long-term stuff then, because and we've certainly talked about this plenty of times where there's plenty of things in medicine that we do to make ourselves feel better, right? You know, and it ranges from giving antibiotics to even like working cardiac arrests, you know, for 75 minutes because we can. We do a lot of things that are just it's a very broad range of things that we do to make ourselves feel better.
Courtesy on these.
Yeah, right, exactly. And you know, and Dan, how many rescue missions have we done where like this is not an ALS patient, this is, you know, it's a transport. But so Salim, talk about some of the long-term risks of doing this, because pre-hospitally we are very, very focused on the here and now. I care for 20, 25 minutes, and then it's somebody else's problem. So
Checkers, not chess.
Exactly. So
there's two main issues. The first we've already kind of talked about, which is antibiotic resistance. You know, the more antibiotics we give, you know, more broadly, the more potential for antimicrobial resistance. And the other thing that doesn't get talked about is the rates of C. diff, just from getting doses of antibiotics. And we see this in the hospital. You don't see it pre-hospitally, but we see it in the hospital where people get started on these broad spectrum antibiotics. We now have to continue those broad spectrum antibiotics. They potentially become resistant over the long term, but in the short term, they can also develop C. diff. And it's a nasty disease to treat. It is really hard to treat people who get bad C. diff. The second part of it is that, and there's going to be a lot of people that don't like hearing this, but I'm just telling you the facts. Giving antibiotics without drawing cultures is a problem. And it has been shown. There was a study called the FABLE trial that looked at culture positivity in people who got one single dose of antibiotics versus those that didn't get that single dose of antibiotics. And there was a 12% absolute difference in false negative cultures from the people who got the antibiotics and didn't get blood cultures. That has effects in terms of streamlining antibiotics and taking people off antibiotics like downstream. And so again, you don't think about that in the pre-hospital world, but a 12% absolute risk increase in false negative blood cultures is not insignificant. It is now we're having to keep people on these antibiotics longer, and we can't de-escalate them because we don't have those cultures. And so I think if you're going to be in the practice of giving antibiotics pre-hospitally, you should probably be in the practice of drawing blood cultures. And like, I don't think people are going to be very happy about me saying that. But again, I'm not saying that I'm trying to take away this cool thing from the pre-hospital world. I mean, I'm all for things that are beneficial, but like, remember that what we do at the initiation of care is continued throughout the rest of care as it gets to the emergency department, as it gets to the ICU, as it gets into the hospital. And so if we cut corners and don't do things correctly at the initiation, that has impacts on downstream care. And so those are my two big things, are that we're going to increase antimicrobial resistance. We're going to start seeing more C. diff, and we're already seeing these. I'm talking about it like as if it's going to happen. It's already happening. And then we're going to start being able to not de-escalate people's antibiotics downstream because we're not getting these cultures as we're giving these antibiotics, which haven't been proven in my mind that giving it, a whole hour faster or 30 minutes faster is going to, completely change their mortality. And so those are kind of my big issues with like the flip side of the coin of why I think this is a bad practice just in general.
So we'll do this last one and then we'll wrap it up. If I'm in a position where I'm a clinical director, a clinical coordinator, and I want to try to implement this sepsis criteria, is this using antibiotics and cultures? Is that an approach that you think pre-hospital systems should use, or are there better, more effective ways for sepsis treatments to be done pre-hospitally?
So there have also been studies looking at cultures drawn pre-hospitally, and they tend to be contaminated much more than the ones that are drawn in the hospital. Yeah.
In the field? Really?
In the field, man.
Weird.
And again, it's not it's not that people don't know how to draw blood cultures pre-hospitally. That's not what I'm trying to say with that statement. What I'm saying is that you're in austere environments. You're much more limited in terms of man and woman power. You're having to do the things to resuscitate the patient and get them to a facility where they can be taken care of. And the sterility of your blood cultures is probably low on your list of things that are a priority. And so it's not that you can't do it. It's just, how many more things are we going to add to the checklist of things that need to be done pre-hospitally? And so I don't know that 30 minutes is really that big a difference, but I have one caveat here. So I already talked about if something's obviously infected and you want to give them antibiotics, I'm not going to argue with you. The second caveat is if I pick up a patient and I think they're clearly hypotensive, they're like septic shock, they're already at the end of the cliff that they've already fallen off the cliff. And giving antibiotics sooner, maybe in that population, does make a difference. But just all comers that meet SIRS criteria, I think is a bad practice. And so that's kind of where I would leave it from a clinical standpoint, that if you're going to do it, it should probably be the patients that are on the far end of the spectrum, not just anybody that meets SIRS criteria. If you're going to do it, you should probably try and draw blood cultures before you give the antibiotics. And if you have a short transit time of like 20, 30 minutes, are we really doing a service to our patients by giving them those antibiotics? Or would they be better served getting to the hospital, getting the things that they need, the data points, including cultures, and then getting that antibiotic? I'm just asking a question. It's like a sincere question of like, are we really doing them a service, or are we causing potentially more harm?
What about,
and I think
what about the idea of just, hey, our job is maintaining perfusion, getting good access, recognizing somebody is potentially septic, getting good access, going with a fluid bolus, not fluid overloading them, but being aggressive with pressors for that patient who has a low blood pressure or is in septic shock. So you have this in a nice wrap package so the ED can continue the care. I like to think of it as playing chess, not checkers. What we're doing is going to impact things down the road.
So what you're basically saying is, let's do the basics well. Let's not focus on all the fancy bells and whistles, right? It's not sexy, though, to say that, but that is actually it. In cardiac arrest, it's the same thing. How about we get CPR right? How about we get how we compress people right? How about we minimize pauses right? How about we do all the stuff that actually affects neurologic outcome, right? So that's what your statement is basically saying. Instead of getting to all these fancy bells and whistles, why don't we just get the basic shit right? And that's what I'm basically advocating for, is this is a bell and whistle that is not a benign thing.
I love that, and I think it's a perfect place to end it. Salim, thank you so much. When we're doing EMS, we want to make sure we do the simple things right. We don't need all the extra stuff to make everything look fancy. The idea is that we're trying to reduce our patients' time in the hospital to make them better when we get to the hospital and have them get better and out of the hospital faster. Dr. Salim Rezaie, thank you so much for joining us. We'll talk to you guys next time.
Take care.
Thanks for having me, guys.